Hello and welcome to this episode of our Rhinoplasty for Residents and the Foundations of Facial Plastic Surgery webinar series. We really hope you have a great time watching this show.
Hear me out there? Good evening to you. First of all, I want to say that every organization or every successful organization needs a Cameron McIntosh. The enthusiasm, the energy that he brings, I think we're all feeding off it at the moment. Cameron, just amazing what you're doing for the Rhinoplasty Society and what you've done for facial plastic and bringing this cohesion together of the various specialities. Thank you very much. I'm in private practice at St. Augustine's Hospital in Durban. My other big passion is trauma. I do a lot of lecturing in advanced trauma and life support. To date, I've done 90 courses, of which I've done 10 as director. For my sins, I'm unfortunately director of the entire trauma service in my hospital, which is a level 2 facility. What I haven't told Dion is I've done a lot of cadaver courses. I've been to the St. Louis University School of Medicine, great cadaver facial plastic courses with David Holks and Alan Putterman. And those are quite crucial to get your basics and understanding of anatomy. Durban is on the east coast of South Africa. It is on the Indian Ocean side. In the last couple of days, I've been looking at the temperature gauge. Professor Perkins was saying what a beautiful day it is in Indiana. This is supposed to be the peak of our winter, and we're looking at 23 degrees, 24 degrees during the day. A bad day for us is approximately 8 degrees. You've got to wear a jersey or a big jacket. I live 25 minutes inland, and it gets substantially colder. This is our boardwalk, our promenade in Durban. It's approximately 7.5 kilometers long. In the distance, you can see it starts at our Deepwater Harbour and goes to the next river mouth. It is fantastic. If you're a fitness guy or a cycling guy, you've got 15 Ks of magical view right next to the ocean that you can ride in. For those of you that watch National Geographic, you might have come across a series called Snakes in the City. I don't know whether we should be proud of this, but we've got about 5 or 6 bad guys that live in our metropolitan area and the rural areas. They have a National Geographic team that follows this guy around apprehending these snakes out of gardens as our metropolitan area expands out there. Some of the big mambas that we get here will send chills down your spine. I've got no financial disclaimers, no financial obligations. I do need to acknowledge Joe Nyamtu, who has taught me a lot of my facial plastic surgery. I was chatting to him on Thursday, and just to get permission to use some of the material out of his book. If you're looking for a facial plastic book, this is so practical, it's so honest. And Joe tells me that the 3rd edition is on its way out early next year. Well, I've got 30 minutes to tell you about rhytidectomies, and then we're going to be followed by a giant in the facial plastic world in Professor Perkins. No lecture is complete without a quick review of the anatomy. I'm going to talk to you a little bit about my experience with radio wave technology. I would love to have told you about conscious sedation and how our experience and how we do it here. And we've got there's a latest booklet out by the South African Society of Anesthesiologists from Professor James Rilifse from Stellenbosch University, which is an absolute must if you practice conscious sedation in your offices. We're going to briefly touch on some preparation, the choice of incision, technique of superficial rhytidectomy. I am going to show you some cases, but today's exercise is not about showing you befores and afters. The objective in my private practice is to get a refreshed look in my patients, and most important, I do a lot of attention to scar management. So what is the definition of a superficial rhytidectomy in my practice? It's certainly not a skin tightening procedure. Well, I might as well send it down to the aesthetic physician and they can put some threads into a patient's face. It is not an undermining of the subcutaneous tissues and then putting bolster sutures in. Yes, we do use bolster sutures, particularly to tighten up the neck. It's about a smearectomy. It's about taking approximately 1.5 centimeters of the SMAS layer away from just below the zygomatic arch and to the angle of the mandible, and then I'll undermine the SMAS approximately 1.5 centimeters, and then I suture that to the area that I've excised, and then I will put in some bolster sutures. I do deep plane facelifts, but I must acknowledge I don't do them often, and certainly not in the league of Professor Perkins. So every facial plastic surgeon should have this graphic in his offices. I've got a big one in my one room. This is out of Joe's book, but what I'm wanting to show you here and alerting you is this is zygomaticus major and minor. That is where I start my deep plane facelift. And you know when you got there, because just below that is McGregor's patch. And you never forget McGregor's patch, because every time you hit it, it's like water in a well coming out of the ground. And it doesn't matter how many times that you bovie it, you use your bipolar or your cautery, it just continues to well out, and you have to go back and keep on getting it under control. My other point of reference is the parotid mesenteric fascia. We talk about tunnel vision. When you're in this flap and you've got your eyes inside the flap, it's so easy to get so disorientated. So one of my take-home messages is get yourself into a routine. I'm into triple figures on the number of facelifts that I've done, but I still routinely go through the anatomy beforehand. I try and visualize the ligaments when I'm lifting my initial flaps, because that's a really good orientation as to where your SMAS layer is, and where your parotid mesenteric fascia is. And these are graphics courtesy of Joe's book. So when you start your anterior facelift incision, you've got to be in that layer. The minute that you clip the superficial temporal artery, you know you're too deep. And that is one of the complications that I've had when I've looked at my first 60 facelifts. So that is quite crucial that you understand exactly what layers you are. There's multiple layers, as we know, and it can be very confusing. So my next big facelift and brow lift is on Friday. I have a ritual that I go through every night before a procedure. And I'd like to equate myself to Warren Buffett, without a doubt, possibly the greatest investor in the world. And on Warren Buffett's desk, he has the Father of Investments book, which is Benjamin Graham. And Warren will acknowledge that he's been through Benjamin Graham's book about 7 or 8 times, and he picks up a pearl of wisdom out of that book every time he goes through it. The same happens when you go redo the anatomy, and you can't go through anatomy enough. Why do we go through the anatomy? It's not about the normal. It's about the abnormal. It's about that revision case that comes in your door, that somebody else has done bolster sutures, somebody else has lifted a SMAS layer, somebody else that's done a deep plane facelift, and the anatomy is distorted. It's about understanding what the abnormal anatomy is. And these two pictures on the right-hand side are crucial to my understanding of anatomy. The picture on the right, that is Erb's point or McKinney's point. It is approximately 6.5 centimeters below the external auditory meatus. I measure it every time. We may not get it exactly right, but it gives me a really good orientation to where those major nerves are. And the external jugulars in that area. This, in my opinion, colleagues, is possibly one of the most challenging parts of your dissection, is understanding exactly where Erb's point is without having to violate the sternocleidomastoid fascia. Because if you do and you lose your orientation, you're going to clip the greater auricular or the accessory nerve, which is the nerve in yellow. No anatomy lecture is without reviewing the vascularity, and we've alerted you already to the superficial temporal artery and the external jugular. And I'd like to later on discuss, and I'm sure Professor Perkins is going to talk to us, particularly when he does his anterior platysmoplasty, about some of the big blood vessels that go over the surface of the platysma muscles as you start dissecting from posterior to anterior. And if you don't have good access, you're going to hit them, and it just makes your life a lot more difficult in your dissection and trying to control those bleeds. I really want to share some of my experience with radio wave technology. The machine over here, that is my radio wave machine. This is another machine that I do not leave home without. It is an LED light that attaches to all my retractors. This is the Klein infuser, which I don't use that often. This is for tumescent liposuction and for hydrodissection. We'll use that under general anesthesia. Hydrodissection, when you're injecting these patients, it's damn painful. And even under deep sedation, the patients in my practice buck, particularly when you're doing a hydrodissection in the forehead. So perhaps not in this country, but I know in the US it's a little bit more popular. Why do I use radio wave as opposed to electrosurgery? I don't use blades apart from a number 11 in my facial plastic practice. I exclusively use a radio wave. Electrosurgery, without being degrading, is a sophisticated soldering iron, whereas a radio wave operates at a much higher frequency. It does not provide the resistance to the tissues that sometimes electrocautery has. Your tip never gets hot. It causes intracellular volatilization. All your energy is channeled into the cells. It creates an energy. There's a vibration. Steam is generated, and it bursts the cell. And there's much less tissue that's damaged. And that's been shown by Joe Nyamtu, where he's looked at comparisons between radio wave and CO2 Fraxel laser, and he's found very little difference in the skin healing afterwards. Most important from a litigation point of view, you never need to put a pad onto the patient. My antenna sits about a meter away from my patients. We had such an eloquent lecture 2 weeks ago with Deepak in New York and Hamza in Cape Town. And I just want to show you, this is how we use a radio wave to do a transconjunctival blepharoplasty. And I'm going to share a short video with you with how we utilize this. And you can see that we're not only able to dissect beautifully with this. I've now progressed, believe it or not, to a Colorado needle, which is a lot. I've progressed to a Colorado needle on the radio wave, and it really provides a lot more control, and there's a lot less bleeding. So the ability to make an incision with simultaneous coagulation is obviously a tremendous advantage to me. There's less bleeding. It obscures your surgical field, and hopefully I'm going to show you with the results afterwards that we have less swelling, less discomfort. On pure coag, I use, for incisions, we use pure coag. It has a bipolar component to it. And in pigmented skin, we'll use a pure cutting for skin as there's less lateral damage. So believe it or not, if you have a look at some of the leading facial plastic guys, they like to use big blades. And there's a reason why you use big blades, because you have much more control over your incisions as opposed to a 15 or a 15C. But blades do create 15 to 20 microns of injury laterally in the skin. Whereas you can use a radio wave, which produces as little as 20 microns of tissue damage. Artifact is minimal. I use this in my practice daily. And whereas electrosurgery or cautery has a low wavelength, there's more char that's formed, and there's more tissue damage. This is another video which you're going to see this patient a little bit later on, if I can find my cursor. This is the incision that we make for a facelift. Sorry, let me just go back there. And just find there we go. So I do not go into the hairline. I go below the sideburn, and we bevel our incision. It is very important to bevel your incision through the hairline so that your follicles grow through the superior part of your flap. It then goes into a beak at the superior part of the helix, and then we utilize and we employ the geometric broken line theory. I go into the helix of the ear with the radial wave, so that when we now put our tissue together, you're not going to see where that scar is, and you want to hide your scar as much as possible. So incision management, incision tear is very important in these patients. So before I start preparing my patients for a rhytidectomy, I'm a massive fan of microneedling. I'm trained in CO2 fractal laser. I don't use it in my practice. The reason why I like microneedling is your wound healing cycle is 28 days. You cause a controlled skin injury without actually damaging the epidermis. So our objective is, colleagues, is to get near vascularization and to get near collagen genesis. We want to release some growth factors. We want to release transforming growth factor beta and alpha and platelet-derived growth factors into the skin. So I try and sort of prep the skin before I start this type of surgery, and I do that a month before. And then my patient then goes back to the therapist that I work very closely with, and she starts again about approximately a month later. And this is personal communication through a close friend of mine with Lance Setterfield, who's got a really great book on microneedling. All preparation is about planning your where your skin creases are, your skin fractures are. That's the preferred incision that I make on the right-hand side. And I always go through these type of diagrams because it just gives me comfort and security on where we can work in the safe zone, and where we're not going to injure anything, and we're not going to injure any one of the branches of the facial nerve. No amount of money is going to salvage an unhappy patient, particularly when you clip one of the facial branches, and particularly when you're doing facial plastic surgery. This is a tip that I got from John Owsley, who is a plastic surgeon out in the UCLA area. It's taking a bit of soft tissue away just in front of the helix and just creating a divot. You want to make sure that your soft tissue drape is passive and that it sits on the tragus. There's nothing worse than pulling the skin as tight as possible to give a wind tunnel look. And what happens is your tragus is quite flexible, particularly our otolaryngologists will know that. And the skin then just pulls the tragus forward and you look straight into the external auditory meatus, aesthetically pleasing. Our preparation is our incision placements. I draw in as much information as that I can possibly do with a patient in a sitting position. Sorry guys, I'm not a fan of doing facelifts on males. It's a completely different animal to dealing with the female skin. Males, they are frustrating to work on. Their skin is thicker. They've got sebaceous glands. They've got hair follicles. They bleed at every single turn that you lift the flap. It's very taxing. And then very important is that you've got to plan your incisions with men so that you don't have the hair growing out of the tragus. So you've got to plan your incisions very carefully with men, that your facial hair is in an aesthetically pleasing place. What you do in the front is very important that you duplicate behind the ear. And scar management, in my professional opinion, behind the ear is just as important as in front of the ear. So I wanted, this I think is out of Alan Putterman's book, which is a really great book on ocular plastics. And if I can find my cursor, the vertical incision here, in my opinion, is too high. This is how you're going to violate the cartilage of the ear. It should be further down. Here we go. possibly in this area here. So first of all, you've got some skin to work with when you sew it back. And I see some patients that walk in my door and some cosmetic surgeons that will make their incision right up into the hairline. But then we know that you're going to create a dog's ear here. That means you're going to lose all this hair here. So I would prefer most probably to go where B is. But remember that your incision for the residents out there, this incision it changes according to how much skin you need to take and you need to tighten from the neck. If you've got a large amount of skin that you need to move behind the ear from the neck, you need to make that incision a lot more acute. Again, that incision needs to be beveled so that you can create an environment so that your skin follicles can grow through that incision and you can bury it to the best of your ability. This is the decode classification. I'm not going to go through this, but you need to have some sort of baseline to work with. But particularly to my colleagues out there that maybe are not orthognatically trained, this is the type of case when you look at the facial angle, angle here, that you might want to consider when you're doing a facelift to put a silastic chin in here. Don't do that. First of all, you've got a low slung hyoid bone. Rather consider doing a genioplasty here. It's going to pull up that geniohyoid muscle. You're going to get the correct facial angle that you want, but it's also going to put your hyoid bone in a much more aesthetically pleasing zone. The same with your patients with massive jowls. First, have a look and see what their malocclusion looks, if they've got a malocclusion. It doesn't matter their age. We've got amazing technology today, particularly with deep class 2 malocclusions, where rather get their jaw advanced, move their chin a little bit further forward. It's going to put these poor chin lip throat lengths are very difficult to manage unless you are a very advanced surgeon like Professor Perkins or Joan I am too. So that's just a pearl out there is silastic chins are great. It's simpler to do. But the problem is you get erosion of bone, but it also, you want to try and get that neck in a better position and your chin lip throat length a lot better than just putting a chin implant in. My preparation starts with, and I'd love to share with you our patient sedation and analgesia, but we just don't have time. We use a lot of Versed or midazolam, followed by Sublimase. Our mainstay drug is IV propofol, but the drug that's really changed the way that I do facial plastics is Presidex or dexmedetomidine. We'll then do our infiltrate. So a hydrodissection consists of 20 mils of Marcaine with adrenaline being 1 in 200,000. It's infused into a bag of 100 mils of saline. This is damn painful for the patients. And that's why we really put them at a deep level. And I do this manually. That's my opinion. And we use we'll use a spinal needle of 23 gauge to administer this. So I'm going to take you through a couple of cases in my practice because time is so short. So this is a 68-year-old lady that comes to see me. I never render advice and say you need this or you need that done. I listen to what my patients want from me. She wants to look refreshed. She doesn't like the excess skin underneath her eyes. We could look at the number 11s and talk to us about some Botox, possibly some CO2 Fraxel laser into her forehead, possibly even a brow lift, but that's not what she wants. So we discussed the feasibility of a facelift, an upper blepharoplasty, and some fat grafting. I'm a massive fan of fat grafting. I love the biology. I love the physiology of and understanding the dynamics of fat. I try and follow some of the stuff that Timothy Martin does and has published, and he really gets outstanding results. And I'm going to show you a case just now where we've just done fat grafting purely and then followed that up with a facelift. So this is what my patient looks like 1 week after the procedure. So there's minimal bruising. When you do deep sedation, my patients go home within about 2 hours of the procedure. One of the pearls is guys out there, You never leave home. You never go out of town on the night that you're doing a facial plastic procedure. They need to have access to you, and you've got to see them the next morning, because if you want to see complications, see them a couple of days later. The picture on your right-hand side is her a year down the line, so we're able to maintain them. This is a picture behind her ear, and I want to just alert you to, well, we could be hypercritical. There is an adhesion there, but look where that other incision is. And so I never use skin clips. I think that skin clips, you don't get great healing with skin clips. They cause raised rolled lesions, areas at the back. I see skin clips being placed in the hair in the anterior tragal area. And you see those marks a mile away. You close this with 4 vicryls, which I take out after approximately 5 days, and you get a far more superior scar result behind the ear as well as the front. So as I said, what you do in the front, you need to make sure that you duplicate posterior behind the tragus. And this is what she looks like a year afterwards. And yes, she has got a lot of wrinkles, and we could do some dramatic work with chemical peeling and with CO2 Fraxel, but your patient's going to need to want that. I put this in because I'm allergic to blood. I make sure I have all the right equipment. I have bipolar. I have Colorado needles, and I was quite admiring this picture on the right-hand side. Just to orientate you, this is the beginning of the facelift, but I was horrified. And this is the take-home message. Look at the position of my scissors. Absolutely terrible. They're in the wrong orientation. You never put your scissors in that dimension. That's how you're going to start violating the the parotid mesenteric fascia and your SMAS, and you're going to end up clipping one of the branches of the facial nerve. So you always have your facelifting scissors pointing upwards. It's a lot easier with your dissection because you can monitor it through the skin. And if you're using LED lights, you can also see the light shining through the skin, so you know you're in the right plane, and you continue to be in the right plane. This is my second patient. I'm sorry, I'm not a fan of threads. Maybe I've got a jaundiced eye. I see too many patients that walk in my door. She's had approximately $1,200 of threads placed in her face, and every time she turns sideways, she has them break. I've heard of patients in my town of having 75,000 Rand, which is about $6,000 of threads put in their face, and they last 18 months. For what? She's exhausted, she's tired, and she's asked for a facelift. So this is her intraoperatively. This is not pulling the skin. This is getting an idea of the vectors of where you need to place the skin. Once you've done your smazectomy and you've repositioned your SMAS in the correct place, your skin should just lie passively, and that's when you start excising it and contouring it to fit around your ear. We recognize there's going to be a dog's ear behind the ear, and there might be a bit of bunching of the skin behind there, but that's hidden. That's what she looks like 2 weeks afterwards. You can see minimal bruising, and I pay special attention to scar management. That's 2 weeks afterwards. Some great work done in the Journal of Oromaxillofacial Surgery by Meredith August and Phyllis Orion on soft tissue changes that occur following orthognathic surgery. Your soft tissue changes occur up to 1 year after any bony changes. And I always say to my patients, it's going to get better with time. And you can just see this is her 5 months afterwards, or 4 months after the surgery. She looks refreshed. And you've got a patient that doesn't look like that she's had an extensive facelift. This is my last case, which I'm going to present to you, and she's been a patient of mine for a long time. The pictures on your right-hand side, that's just after fat grafting and applying the principles and the way that Timothy Martin does it. That is just fat grafting, no lower blepharoplasties, just fat grafting. But she's now come back to me in the last couple of weeks, and we're going to do a brow lift on her and we're going to do a facelift on her. So this is the preparation that I do, and I just want to show you, there's Erb's point. That's 6.5 centimeters. That's where your sternocleidomastoid muscle is. That's where your greater auricular is going to be. That's where your accessory nerves are going to be, and your external jugular. In my opinion, is that one of the toughest dissections, apart from when you start lifting your deep plane facelift, is behind the ear. You run a fine line here, colleagues, is that you've got to lift a subcutaneous flap while you don't violate the hair follicles, but directly underneath that is the sternocleidomastoid fascia, and it's firmly attached to that underlying skin. And you've got to nip, you don't push, so that you can just lift that skin off the sternocleidomastoid and gently go down to the area which I've alluded to, which is Erb's point. Now, very important, which you don't see in textbooks, there's a transition zone just over here. And just when you get from there, you fall into the loose areolar tissue and you think, sure, I'm home safe here. No, you're not. Because this is where you need to take special care when you place your facelifting scissors. You do not put them horizontal. This is where you spread. And you spread vertically because you want to get on top of your platysma muscle here. And it's not that easy to see the red of the platysma muscle coming through. But once you get on top of it, that's where you need your LED lights and are so crucial. They open up a different world down there. If you haven't used LED retractors, you need to start using them. They open up a massive world down there, because hopefully what Steve's going to show us is in the anterior part of the neck. As you get to the anterior part of the platysma, there's a whole lot of blood vessels that run on top of that. And if you don't see those and you go and clip those, you're gonna be there for many minutes trying to bring those under control. This is my patient 1 week afterwards. She's very bruised. She's had a brow lift as well, and we'll see her later on in the year on the 2nd of November. And you can see how important I take into consideration scar management. I take at least half an hour to close each side. And then we look at behind her ears. These are the vitral sutures that we've placed, and I just took those out last week. And on your right-hand side, it's important to see that the closure behind is just as good as the closure in front. So, ladies and gentlemen, colleagues, some of the lessons I've learned after listening to Mark Constantian's outstanding lecture last week, and I would urge everybody to go and listen to it, because we all need to know about the psychology of patients. I've just looked at the complications that have occurred in my practice, and you've got to be critical, because the toughest 10 facelifts are your first 10. And I used to phone up Joe and I am too in the US and lament on the complication that I've had. And he says, these are the toughest 10 that you do. But it then just gets easier, but you can't take your foot off the pedal. And that's why you've got to have a ritual that you go through every time you prepare yourself for a facial plastic procedure. I've had 2 significant bleeds from the superficial temporal artery and a large hematoma, which presented 72 hours afterwards. And I just saw litigation and complications and problems. So unless you go and lift that flap completely and aspirate and evacuate that flap with that hematoma, you're going to continue to aspirate blood from as long, or the breakdown of blood for at least 2 weeks post-op as the clot breaks down. I'm into triple figures now with a number of facelifts that I've done. I've never had a fallout of any branch of the facial nerve, and I just hope to never have one. I know the old analogy that if you haven't had one, you haven't done enough. Well, I hope I haven't done enough to get one of these. Skin adhesions, particularly when you're doing deep plane facelifts, you've got to pay attention to the skin adhesions. You sometimes don't see them afterward initially. They come back a week later and you see them. Very easy to manage just with some local anesthetic. I've discussed men and women and a transition zone. Something that I do in my round face patients, if you can call them that, is I like to get a large open liposuction or a large liposuction cannula, and I like to remove the excess subcutaneous fat, but also to smooth out the lumps and bumps afterwards that the underlying soft tissue creates. And then obviously you go in with your bipolar if there's any cautery that to be done. I'm in my 50s, and it's taken me possibly 8 years to learn how to become completely ambidextrous. So when I do facial plastic surgeries, I use both hands. So I'm a left-handed surgeon historically. I don't have to move my entire equipment, my trolley, my staff around to the other side, my assistant around. I just turn the head sideways, because when I need to go onto the right-hand side, I'm extremely blessed to be able to use exclusively my right hand to do the entire dissection on the right-hand side. In fact, today, when I do open brow lifts, I exclusively use my right hand to do the dissection. So for the residents, for junior guys out there, this is fine motor coordination. Get in there, start using both your hands. It's of massive advantage. It reduces your fatigue in these patients. There's so much to discuss in this amazing subject of facial plastic surgery. I wish I could have done a step-by-step approach to how we do these procedures, perhaps sometime in the future with cadaver workshops or another lecture series. I thank you so much for your attention, and I just hope that you've been able to take away at least 1 or 2 pearls of wisdom from this evening from our presentation. Thank you.